Hi everyone, I'm Anton, a psychiatrist, and I'm really happy to have you here on my channel. If this is your first visit, I'd love it if you could hit that like button and subscribe. This is the very first video in my video lectures series, and today we're going to dive into the topic of using psychotropic medications while breastfeeding. But before we get started, a quick disclaimer. Some of what I'm going to share in this lecture is aimed at mental health professionals. If you're receiving psychiatric care, please don't start or change any psychotropic medications on your own. Always check with your doctor first. What determines whether a medication passes into breast milk? Several factors play a role. First is molecular weight. In the very early and very late phases of lactation, larger molecules can pass more easily, but for most of breastfeeding, only smaller ones cross effectively. Compounds up to about 200 daltons transfer readily, sometimes up to 1000 daltons, but anything larger faces significant barriers. Drug concentration also matters. Most medications enter milk through diffusion, although a few rely on active transport mechanisms. Lipid solubility is another key point. Since the membrane is lipid-based, fat-soluble drugs are far more likely to pass into breast milk. The degree of protein binding influences transfer as well. Drugs that bind strongly to plasma proteins have more difficulty crossing. Likewise, highly ionized compounds have limited passage. The volume of distribution also shapes availability. How widely a drug disperses in maternal plasma affects the amount left to move into milk. The half-life is relevant too. Shorter half-lives encourage more rapid clearance back into the mother's circulation. And finally, the pKa of a drug can be decisive. Weak bases, for example, may become trapped in the relatively more acidic environment of breast milk compared to maternal blood. All these variables interact, and each medication represents a unique combination of factors that determines how much, if any, transfers into breast milk. It is equally important to recall some fundamental principles of drug excretion into breast milk. I've often had patients who continued a medication throughout pregnancy suddenly say, "I don't want to expose my baby through breastfeeding," but that reasoning doesn't hold up. During pregnancy, most medications readily cross the placenta, and the concentration of the drug in the fetal bloodstream closely mirrors that in the mother's. In that situation, the infant's serum level is determined entirely by the maternal dose and her ability to clear the drug. Breastfeeding is different. Here, the infant is exposed only to a fraction of the mother's dose. Both the amount of drug transferred into the milk and the infant's own clearance mechanisms come into play in determining serum levels. So in pregnancy, only maternal factors govern the infant's exposure, whereas in lactation, Both maternal and infant factors are involved, resulting in a much lower overall drug level. In other words, if a woman safely used a medication during pregnancy, there is no logical reason to discontinue that treatment once she begins breastfeeding. The key point to remember is that the mammary gland is neither a major organ for drug elimination nor a storage site. In other words, once a medication enters the mammary gland, it is neither actively cleared from it nor retained there. The infant is exposed only to the amount of drug that passes into the milk at the time of feeding. It is not the case that the drug accumulates in the mother's plasma, enters the milk, and simply waits for the baby to consume it. Instead, the infant receives milk that has been produced during feeding, and the exposure corresponds to the drug excreted at that moment. Equally important is an understanding of infant pharmacokinetics, how medications behave in the newborn's body. At birth, gastric pH is neutral, then falls within the first day and gradually returns to neutrality by around day 10, directly influencing drug absorption. Intestinal transit times are longer than in adults, and fat digestion is less efficient. Gut microbiota, essential for the infant's health, also vary dramatically depending on the mode of delivery. Babies born vaginally acquire a few different microbial profile from those delivered via caesarean section. Particularly significant for psychiatric medications, the newborn's blood-brain barrier is far more permeable than that of an adult, meaning these drugs more easily reach the infant's brain. Moreover, many cytochrome P enzymes, including cytochrome P450, 1A2, 3A4, 2C19, and 2D6, have reduced activity in infants compared with adults, all of which are key to metabolizing common medications. Taken together, these factors result in slower drug elimination in infants. Thus, when assessing infant exposure, it is not enough to consider only the amount of drug present. One must also account for the distinct differences in clearance and metabolism between newborns and older children. Another critical aspect is balancing the risks of taking a medication against the risks of leaving the illness untreated. Many people frame this as weighing risks against benefits, but in the context of a postpartum mother and child, the calculation is more complex. We must compare the potential risks of the drug for both mother and infant with the risks posed to both if the illness goes unaddressed. The mother's need for treatment is central, and it is vital to remember the possible negative consequences for her health and for the family as a whole if the condition remains untreated. It is also necessary to consider the mother's access to and response to non-pharmacological therapies. Some women may lack access to psychotherapy, while others may not benefit from it, making medication the most viable option. In addition, clinicians must keep in mind the impact of a drug on milk production, the extent to which it passes into breast milk, how much of it the infant absorbs orally, and any potential adverse effects on the child. The infant's age, including whether the baby was born prematurely, is a crucial factor in this assessment. Infant intake and clearance are also key parameters in estimating the actual dose received. During the first day after birth, clearance is quite limited, but so is intake, since a newborn's stomach holds only about 5 to 7 milliliters per feeding. Premature infants may have even less capacity to metabolize or eliminate certain medications compared with full-term babies. Additionally, infants with kidney or liver impairment may struggle to clear drugs that depend on those organs. As the child grows and begins consuming other foods, the proportion of breast milk in the diet decreases, naturally reducing exposure to the medication. At first glance, all of this may feel like an overwhelming volume of information, but fortunately, there are excellent resources available to guide us in understanding the safety of medications during breastfeeding. No physician could possibly retain every detail of the research on lactation and specific drugs, so we consult references. I find myself checking them constantly. It's important to recognize, however, that the literature can only tell us how medications enter breast milk and provide case reports of adverse effects. What we lack entirely are studies comparing the risks to the infant with the risks to the mother, or to both mother and child, of leaving an illness untreated. That is the crucial clinical consideration, and unfortunately, research cannot resolve it. In fact, organizations that comment on the safety of medications in breastfeeding often focus exclusively on the infant. The American Academy of Pediatrics, for instance, issues statements on the safety of certain drugs in lactation, but these assessments are based solely on potential risks to the baby, without accounting for the consequences to the mother or the broader family system if psychiatric treatment is withheld. There are, however, several reliable resources that provide detailed information on how drugs pass into breast milk. One I frequently recommend is Mother to Baby, mothertobaby.org, a website that offers patient-friendly fact sheets in English and Spanish on the use of many medications during pregnancy and breastfeeding. Another is Reprotox, a subscription-based service that delivers highly detailed information on virtually all drugs in both pregnancy and lactation. A further invaluable reference is the book Hale's Medications and Mother's Milk, which clearly explains how medications enter breast milk and outlines the potential risks associated with different treatments. The most comprehensive source, and the one I rely on most often, is LactMed, part of the National Library of Medicine. It provides summaries on nearly every drug used in lactation, including maternal and infant serum levels where available, documented effects on infants, potential impact on milk production, and often safer alternative options. It is accessible through a regularly updated website. While the app is reportedly no longer being maintained, the website remains current and should be the primary resource clinicians turn to. It's worth noting that the FDA has recently revised its guidelines on pregnancy and lactation labeling. In the past, medications were classified into risk categories A, B, C, D, and X, which often created confusion and discouraged many patients from using necessary treatments simply because the meaning behind these letters was unclear. Today, those outdated categories have been replaced by a far more detailed pregnancy and lactation labeling rule. This modern system provides a risk summary that addresses both potential effects on infants and possible impact on milk production. It also outlines clinical considerations, such as strategies to reduce exposure, and presents a concise overview on the available evidence. Overall, it represents a significant advancement over the former system. The challenge, however, is that the final decision now rests squarely with the clinician. Many people preferred the old system because it felt like a simple grading scale. This drug is an A, so I can use it. Yet that approach stripped away important nuance and was ultimately misleading. The new labeling rule is far more precise, but it demands that clinicians carefully interpret and weigh the medical literature as the information is presented in a summarized form rather than a simplistic score. We need to spend a bit more time discussing drug use during breastfeeding and the possible adverse effects that may arise. While it is possible to calculate the amount of medication an infant receives, those numbers alone do not reveal its toxicity. They don't indicate the type of side effect that may occur, nor do they predict the clinical outcome. What ultimately matters is whether the exposure is truly linked to any harmful reaction, and in reality, such reactions are relatively rare. The medications most often associated with negative effects are opioids and central nervous system depressants. This is largely due to the increased permeability of an infant's blood-brain barrier. The closer to birth the baby is, the more immature the barrier remains, and the greater the risk of an adverse response. Immaturity of certain brain regions also plays a role in this heightened vulnerability. In such cases, reactions can result from excessive exposure, whether through a high maternal dose, significant transfer into breast milk, or reduced clearance by the infant's body. what kinds of adverse reactions might occur. It is important to remember that these reactions are merely observed and documented. We cannot say with certainty that they are directly caused by the drug, since no randomized controlled trials have been conducted in this population. In many cases, mothers or clinicians may be more inclined to notice and report a reaction when a medication is being used, simply because they expect one. This tendency may be especially pronounced with psychiatric medications, where stigma surrounding mental health influences perceptions of whether treatment is truly necessary. The most common reactions involve the central nervous system and include sedation, drowsiness, respiratory depression, apnea, seizures, and tremors. Gastrointestinal effects have also been reported, such as vomiting, diarrhea, and poor weight gain. It is well established that polypharmacy increases the likelihood of adverse reactions, or, at the very least, the chance of observing them, given the absence of randomized trials. Another key factor to consider is maternal dosing. During pregnancy, clearance rates for certain drugs increase, leading to higher prescribed doses. This is particularly evident with lamotrigine, which is cleared more rapidly through glucuronidation, and lithium, which undergoes faster clearance due to elevated glomerular filtration rates. If these doses are not reduced back to pre-pregnancy levels after delivery, the infant may be exposed to higher than expected amounts of the medication through breast milk. When an infant has been exposed to medication in utero, it is often difficult to determine whether any reaction observed in the early postpartum period stems from that prenatal exposure or from breast milk. Consequently, the reported cases of adverse reactions cannot be confidently attributed to the medication itself. They remain anecdotal, since no randomized controlled trials exist in this context. The central message here is that what matters most is not the calculated infant dose, but the actual effect on the child. Central nervous system and gastrointestinal symptoms have been observed, yet none of these findings come from controlled studies. They are simply reports of effects noted in the postpartum period, a time when caregivers may be more inclined to notice or expect them, knowing that the mother is taking medication. This makes close monitoring of maternal dosing during both pregnancy and postpartum essential, as it helps reduce the risk of maternal relapse while also minimizing potential adverse effects in the infant. Importantly, drugs that require higher doses during pregnancy often need to be adjusted back to the levels used before pregnancy after delivery to avoid unnecessary infant exposure. We're now moving into the portion of the discussion focused on particular medications and their use while breastfeeding. I'll break this down by categories of drugs. Keep in mind that older medications are supported by stronger evidence. So if you are initiating treatment and selecting a drug for the first time, it's best to opt for an established option, since its safety profile is better documented. With SSRIs, for instance, the longer-standing ones are the agents for which we have the most robust data. By contrast, the newer antidepressants released in recent years lack meaningful research on their use during breastfeeding. They are probably safe, but at this point, we simply don't have the data to confirm it. We also have no evidence that adjusting the timing of a dose in relation to nursing sessions makes any difference. Many clinicians still recommend, for example, nurse your baby and then take your sertraline, but studies don't support this approach. For that reason, I would not suggest giving such advice to patients. Fortunately, SSRIs transfer only minimally into breast milk, and overall, they are regarded as compatible with breastfeeding. One important consideration, however, is poor neonatal adaptation syndrome, which can appear in up to 30% of infants exposed to SSRIs during pregnancy. This condition is marked by irritability, feeding difficulties, and other behavioral changes in the early postpartum period, typically resolving within about 2 weeks after birth. The exact cause remains uncertain, whether it reflects withdrawal, drug toxicity, or another mechanism, especially since it has also been documented in infants whose mothers did not take SSRIs during pregnancy. Interestingly, some evidence suggests that breastfeeding may actually reduce the severity of these symptoms. Thus, continuing the same medications during breastfeeding can offer an additional benefit for mothers who used SSRIs while pregnant. Sertraline is the most thoroughly studied SSRI in breastfeeding and shows the lowest transfer into breast milk, making it a common first-line choice for women starting medication in the postpartum period. Fluoxetine, on the other hand, has a very long half-life, which initially raised theoretical concerns about a higher risk of side effects in infants. Indeed, there are more case reports of colic and sedation linked to fluoxetine than to other SSRIs. For that reason, it may not be the best initial option for mothers who are SSRI naive and beginning treatment after delivery. That said, this does not mean it should be discontinued in women already taking it. Individual responses to antidepressants vary, and often we cannot predict who will benefit from which medication. If a mother has previously responded well to fluoxetine, potential concerns about infant exposure should not automatically preclude its use. In such cases, I would continue with fluoxetine and monitor closely. What about options beyond SSRIs? These medications are prescribed less often in the prenatal period, mainly because other classes of antidepressants tend to carry a higher burden of side effects. Still, there are no established contraindications to their use while breastfeeding. Tricyclic antidepressants have all been studied, and overall, no excess adverse effects have been identified in breastfed infants. The exception is doxepin, which has been linked to a greater number of reports of hypotonia, poor feeding, and vomiting compared with other TCAs. Bupropion, which is often prescribed to women of childbearing age, raises a theoretical concern about lowering the seizure threshold at higher doses. There is in fact a single published case report of an infant experiencing a seizure while exposed to bupropion. In practice, this means the drug should be used with caution in infants who already have risk factors for seizures, though there is no reason to avoid it in those without such vulnerabilities. Mirtazapine remains less studied, but the limited data available show no evidence of harm. And as with SSRIs, the newer agents in this category lack sufficient research. Whenever possible, it's generally best to rely on the older, better documented medications. Now, let's shift our focus to another group of medications, antipsychotics, and how they relate to breastfeeding. I may start to sound a bit repetitive here, but my first point mirrors what I've already mentioned about antidepressants. We have far more information on the older drugs. First generation antipsychotics are well researched, showing generally low milk to plasma ratios, and are widely regarded as safe for use during breastfeeding. Most of the newer second generation antipsychotics are also considered compatible, though the available evidence is more limited given their more recent development. There are a few important points to highlight about some of the more commonly prescribed second-generation antipsychotics. For instance, aripiprazole can lower prolactin levels, which may in turn reduce milk production. This doesn't necessarily rule it out as an option, but it does mean that careful attention should be paid to milk supply, especially in the early stages of breastfeeding, when production is still being established. By contrast, risperidone and several other medications tend to raise prolactin levels, which can actually support milk supply, so they generally pose no concern in that regard. Quetiapine stands out as the second-generation antipsychotic with the lowest transfer into breast milk, largely because of the size of its molecule. In fact, among all the newer antipsychotics, it is the least likely to be present in breast milk. The major exception in this class is clozapine. Clozapine is essentially the only psychiatric medication that is almost universally contraindicated during breastfeeding, primarily due to the significant risk of granulocytosis. If prescribed, it would require close monitoring of the infant for signs of sedation as well as routine checks of the baby's white blood cell count, an expectation that is unrealistic for most parents and pediatricians. Given this high level of risk, women who need clozapine are typically advised not to breastfeed. There is also a complete lack of data on the newest antipsychotic medications, such as brexpiprazole and cariprazine. At this point, we simply don't know how they affect breastfeeding. It's quite possible that future studies will show them to be safe, since there is no clear reason to assume they pose greater risks than the agents we already understand better. Still, the fact remains that no evidence currently exists, and in clinical practice, it is always wiser to choose a medication supported by more reliable data. To wrap things up, let's talk a bit about the use of stimulants and benzodiazepines during lactation. We'll start with the stimulants. First of all, I should mention that as a drug class, stimulants are generally considered compatible with breastfeeding. That said, there are some concerns that they may suppress appetite in the infant and, as a result, slow down growth. For this reason, whenever we consider prescribing stimulants to a breastfeeding mother, the balance of risks and benefits has to be carefully weighed on a case-by-case basis. Benzodiazepines are also considered compatible with breastfeeding, but it's important to keep in mind that this is a large group of medications, and their pharmacokinetic properties can vary quite a lot. Drugs with a longer half-life can lead to excessive sedation or even respiratory depression in the infant. So, when benzodiazepines are used in breastfeeding women, it's generally better to choose those with the shortest half-life. It may also be more reasonable to think of benzodiazepines as situational medications, for example, in cases of acute anxiety, rather than using them on a continuous long-term basis. And finally, just like with other medication classes we've talked about earlier, we have much less data when it comes to some of the newer classes of anxiolytics. That's it for today. Thanks for watching. Don't forget to give this video a like and hit that subscribe button. And take care of your mental health. See you in the next video.